So it's been fantastic to be invited to join this workshop. And I thought a little bit about, what is community? Who is my community? Is it the people I live with? Is it my family? Is it just humans? Is it our environment? And it's really gotten me thinking of around viral hepatitis and community perspectives. What could I share? So what I decided to do was to reach out to my community and the people in South Africa that I work with who work around harm reduction. And you'll see it does reflect many things that are unique to my situation. I'm a fairly privileged white male, so my network is largely white. Half of them are women. Many of them have experienced homelessness, and some of them have been on the street. I think what it does show is our history in South Africa of segregation and exclusion, and it's perpetuated in my life, and COVID has really brought this to the fore. And so with that context, these colleagues in my network have given some of their ideas of what it really means around harm reduction and viral hepatitis in our context. And I'm going to start just speaking through some of the issues related to drug use in South Africa, some background around viral hepatitis, and then go into some of the details of what's been happening in our country in the context of this epidemic. So in terms of harm reduction, for people who don't know, this is South Africa on the southern point of Africa, and we have a population of just under 60 million people. And this is the largest part of where the bulk of people are in the metropolitan areas, which are highlighted in color. And the four major cities that I'm going to be focusing on, and also where the largest projects are highlighted on the screen. So in the center, we have the city of Johannesburg, which is the largest city. It's in the economic heartland of the country, and it's very nearby to Pretoria, which is the administrative capital of the country. And both those cities have got harm reduction services. The needle and syringe service in Johannesburg reaches the most people in the country, about 5,000 people. And in Pretoria, they have the largest opioid substitution therapy program, where they've got around just under 1,000 people on largely methadone. Cape Town is where I'm based in the south. It's a city that has got a long-standing history of a needle and syringe service. The opioid substitution therapy program remains very small, but it is the only city where there's access to hepatitis treatment, but it is limited at the moment to an academic tertiary hospital. None of the other cities have viral hepatitis services. This context that I presented on the screen is where we were at in February 2020. That was just before the start of COVID. And you'll see in the city of Durban, which is on the east coast of the country, there was a needle and syringe service, but it was stopped in 2018 by the city municipality. It was stopped for reasons due to political interference of an evidence-based intervention, particularly because there were concerns of needles and syringes being washed up on the beach, as well as citing reasons of insufficient interaction and engagement with stakeholders. In terms of viral hepatitis, I think it's important to note that while there's been a slow recognition of people who use drugs and drug use being an important contemporary issue in South Africa, the same recognition has not happened in viral hepatitis. There are still so many people who have their thinking patterns and their ideas still based in the 90s, where there was this conceptualization that hepatitis C in particular only affected a very few number of people. Those people who it did affect were infected through contaminated blood products, usually during the hospitalization linked to pregnancy. But yet that's so far from the reality. Recent work that we've done has shown that in South Africa, which has the world's largest HIV epidemic, we also have a large and growing hepatitis C epidemic among people who inject drugs. While the numbers are not enormous, we have an estimated 75,000 people who use drugs, who inject drugs, largely heroin, but also other stimulants. Among them, 1 in 2 is infected with hepatitis C. And in some cities like the city of Pretoria, up to 9 out of 10 people are infected with hepatitis C. So while there has been a recognition of the issues of drug use and also an appreciation of injecting, this hasn't happened for hepatitis C. People have started stirring, but there definitely is not yet an awakening, and there has not been a response. So now coming to COVID. This gives you an example of what's happened in South Africa since April to date. And you'll see we've very clearly gone through our peak, and we're currently actually in the process of an uptrend as you move to early November. The country has had 5 different levels of public health and safety responses. The level 5 resulted in complete lockdown. And it was during this stage where the cities and the country used law enforcement and social development, particularly for people who are experiencing homelessness, to be in large shelters so that there would be firstly protection from the elements to avoid onwards transmission, but the intention was to provide support services for people. As the epidemic reached towards its peak, the restrictions have reduced. However, we know that we're now bracing for what's coming next. In the beginning, there was a lack of clear understanding what needed to happen. There was an underestimation of the number of people who are living on our streets and who are dependent on opioids. You'll see some of these pictures of the scale of the enormity. In the city of Pretoria, on the eve of lockdown, hundreds of people were waiting to enter the large shelter, which was at the Caledonian Stadium. There was not at all a recognition of the numbers of people. In the city of Johannesburg, on the first day, unfortunately, there was the use of force and violence by police, particularly affecting people who use drugs who are on the street. Some of their belongings were stolen, their drugs were stolen, and it wasn't this public health safe response. However, in other cities like the city of Cape Town and Durban, what did happen is a recognition of how important it is to have an understanding of what opioid dependence is and what happens if people don't have access to opioids. It was only when people were in these contained environments. In Pretoria, it was up to 2,000 people, but in each of these cities, there were these large stadiums where people were going through withdrawal. And there wasn't the forethought and the planning to provide opioid substitution therapy. In the city of Durban, there was a recognition and an ability to start providing low-dose methadone as part of long-term withdrawal. And that provided opportunities for stakeholders like the police to really start to understand what opioid dependence is, why people use drugs, and the issues they face. And really it provided this fundamental paradigm shift of understanding in the city of Durban, which had earlier in 2018 stopped a needle and syringe service. In the city of Pretoria, where there was already the largest opioid substitution therapy program, it enabled rapid scale up in that large shelter of opioid substitution therapy. Over the period of COVID, over 1,000 people were started on methadone. However, because of funding price constraints and the unethical cost of methadone in South Africa, the need exceeded what was able to be provided, and the sustainability of continuing those people on methadone is securely threatened. So one of the things that's really important from a harm reduction perspective, and what COVID really showed us, is that we have to take the services to people. Expecting people to come to services, particularly if they're not meeting their needs, is really not an appropriate approach. So there was this recognition of within shelters, there needs to be integrated services addressing the needs of people who use drugs and really thinking about prevention. So the political need to restart this was shown by this individual who brought out the need to move things forward and really take things to the people. An important recognition of the current situation is how poor people really have been excluded. And it's without recognizing the vulnerability that they face, we will never address the issues of viral hepatitis. One of the positive things that happened was the needle and syringe service in the city of Durban was restarted, and people were able to access this important intervention. So just in some corresponding and concluding thoughts, COVID really highlighted the massive number of people who have opioid dependence in South Africa, but it did clearly show that prevention really needs to be the core of our response. Opioid substitution therapy really needs to be scaled up, and that can only be made possible with the dramatic reduction in the price. Political will can be generated, but generally it's lacking. And we're all part of this community, and we really all have to try and be anti-exclusionist. So I didn't come up with a conclusion, but I asked a colleague for his thoughts, and I'll leave you with these recommendations. And I'd like to acknowledge the individuals who were involved in this process, and just to note that the documentation of what's happened in South Africa is being developed in a short brief, which we'll be doing through INSU, which is the International Network of Hepatitis Among Substance Users, which we will be disseminating soon. Thank you.